Hello friends, my name is Ankit. I make educational videos on US healthcare and FHIR interoperability trends. I'm back with another video on how CDC is set to use MedMorph, which is destined to save human lives. If you're new to my channel, welcome. Please like and subscribe to my channel for future updates. What is MedMorph? The Making Electronic Data More Available for Research and Public Health, also known as MedMorph project. It seeks to use emerging health data and exchange standards known as HL7 FHIR to develop and implement an interoperable solution to enable access to clinical data. The MedMorph project fits within the CDC strategic imperative or transforming how data are collected, used, and shared through modern information technology capabilities to save lives and improve health. The initial phase of the MedMorph project was funded by the Health and Human Services Assistant Secretary for Planning and Evaluation, Patient Centered Outcome Research Trust Fund, and executed by CDC Center for Surveillance, Epidemiology, and Laboratory Services Public Health Information Office to advance research and public health goals. The MedMorph's objective includes to leverage the maturation of standards and requirements for certification of health information technology by the Office of National Coordinator of Health IT that underpins many electronic health records. The MedMorph project modeled four use cases that are representative of broader area of research and public health. It includes chronic hepatitis C surveillance, central cancer registry reporting, healthcare surveys, and research supporting standardized data exchange for public health research. The MedMorph reference architecture IG, it aims to minimize the burden on both the sender and receiver of data by providing a common method for obtaining data for research and public health. The CDC established a technical expert panel comprised of a wide variety of representatives with relevant expertise to inform the development of the technical approach, use cases, and the MedMorph reference architecture implementation guide. One of the key area for MedMorph is the healthcare surveys. It includes identifying and collecting hospital, emergency department, and inpatient care and ambulatory care practice data and electronically report these data to a system hosted at CDC. Electronic reporting should increase the response rate of sampled hospitals and ambulatory healthcare providers to the National Healthcare Surveys (NHCS) and the National Ambulatory Medical Care Surveys (NAMCS). This should also increase the volume, quality, completeness, and timeliness of the data submitted to NHCS and NAMCS. Automated electronic reporting without provider involvement should reduce the burden associated with survey participation and reduce costs associated with recruiting hospitals and ambulatory healthcare providers. Detailed use cases, workflows, and actors related to the healthcare surveys use case are documented in the Healthcare Survey Reference Implementation Guide, which can be accessed in the MedMorph FHIR IG's page in the HL7 website. Now, the next IG is MedMorph for hepatitis C, also known as ECR. It leverages existing FHIR infrastructure for electronic case reporting to improve the availability of data that advance national priorities such as eliminating hepatitis C as a public threat in the US, especially if it becomes a chronic condition when not treated. The goal is to optimize access to hepatitis C data already captured within the data source. Detailed use cases, workflows, and actors related to the use case reportable conditions such as hepatitis C is documented in the ECR FHIR implementation guide. MedMorph for cancer registry reporting. Leveraging existing FHIR infrastructure to transfer cancer case information primarily from ambulatory care practice to state cancer registry. The intent is to automate and provide access to data not currently available or available through non-standard or manual method to public health and research. Automation of cancer care registry reporting should reduce the burden of manual or other non-standardized data collection processes that currently exist. The MedMorph cancer registry reporting use case will not replace the hospital cancer registry data collection and reporting methods, which are working well. Hospital-based cancer registry use case, certified tumor registry to abstract data and maintain information on cancer diagnosed or treated in the hospital. The final IG is MedMorph for cancer reporting. Hospital cancer registry and CTRs follow standardized rules and data collection method for the purposes of cancer analysis and research. A national standard formed and processed since 1995. Alternatively, EHR data are primarily used for clinical care and routinely require manipulation and translation to meet the needs of the state cancer registry. The MedMorph Cancer Registry reporting use case is intended to be used primarily by non-hospital provider, for example, physician offices, oncology clinics, radiation therapy center, and by hospitals without cancer registries. Detailed use cases, workflows, and actors related to the Central Cancer Registry reporting use cases documented in the Central Cancer Registry reporting FHIR IG. MedMorph for research. So the purpose of this particular IG is to onboard a new research data partner to a research network and contribute data for research. Current processes involve many non-standard mechanisms for the data to be usable and the data to be transformed to a data model so that it can be queried and analyzed. This process, when standardized, should expedite onboarding processes and deliver better quality of data at lower cost. The key purpose of CDC coming up with this MedMorph FHIR specific initiative is to ensure that they have sufficient data available from hospitals, clinics, and various other ambulatory service organizations, which can be evaluated, analyzed for the analytical pattern, where we can figure out ways to improve the human lives as well as save human lives. This is the MedMorph reference architecture. So if we look at this architecture, the key areas are the knowledge artifact repository, the data sources, for example, EHRs, the SDEA, which is the Health Data Exchange app, which is ingesting this data based on the defined knowledge artifacts, and then the DAX system, which resides within CDC, where all this data is reported and which is used downstream for the analysis purpose. When we talk about the reference architecture, the description of each step in the diagram is mentioned as below. Step 1. A data receiver, for example, public health agency or a research organization, creates a knowledge artifact and makes it available via the knowledge artifact repository. So in this scenario, it could be CDC, which is generating the knowledge artifact. The KR document, also known as knowledge artifacts, that support notification will notify the data sources which are subscribed to knowledge artifact changes. KR system that support notification will notify applications such as Health Data Exchange app SDA, which are subscribed to knowledge artifact changes. Upon initialization or change notification, the Healthcare Exchange app queries the knowledge artifact repository to retrieve a specific knowledge artifact. The SDA receives the knowledge artifact as a response to the query in step 2. SDA processes the knowledge artifact and subscribes to specific events to establish proactive event notification from a FHIR server. For example, the SDA subscribes to the data sources FHIR server so that it can be notified when specific events such as defined in the knowledge artifact occurs in the clinical workflow. The next step is that providers, as part of their clinical workflow, update data that get reflected in the data source such as EHR and further lead to notifying the subscribers of specific events. Please note that no additional data entry is required by the providers to enable MedMorph reference architecture based reporting. So the next step is the data source notifies the SDA based on subscriptions in step 3. SDA queries the data source for patient data. SDA receives the response from the data source with the patient's data. SDA assembles the identifiable data for submission. When necessary, SDA uses the trust service provider to de-identify, anonymize, and pseudonymize data as needed. SDA receives the de-identified, anonymized, pseudonymized, or hashed data as required. The next step is the SDA submits the data assembled as part of step 7 and 7A to local data mart or external data mart. Currently, for the purpose of FHIR specific connectathons, we are not using the data mart. So the data is directly being delivered to the CDC system known as DAX. So we can just skip a couple of steps which are currently not applicable and then move on to the further details. Now, MedMorph reference architecture, it has various workflows. So we'll focus on the provisioning workflow first. the MedMorph reference architecture starts with a provisioning workflow. The provisioning workflow includes creating knowledge artifact, loading them into a knowledge artifact repository, retrieving the knowledge artifacts to create topics or subscribe to changes in a data source. The provisioning workflow involves the activities wherein a data receiver publishes a knowledge artifact specific to a use case. The published knowledge artifact is then downloaded by the SDA. SDA may subscribe to notification from the data source based on the notifications or information within the knowledge artifact. This is the MedMorph provisioning workflow. If we talk about various steps within this workflow, the first step is that the data receiver or their authorized designee creates the necessary knowledge artifact for different reporting or research scenarios and publishes the artifact in the knowledge artifact repository. These knowledge artifacts may include trigger codes, timing constraints, report definitions, surveys, value sets, etc. The SDA queries the knowledge artifact repository for the appropriate artifact. Step P2 could be a result of a use of banned notification, for example, email or SMS, that something has changed, or it could be a response to a subscription notification. The SDA receives the knowledge artifact in response to the query in step P2. The SDA subscribes to topics in the data source based on the metadata received in step P3 for reporting. That's where this workflow ends. The next workflow is the notification workflow. The notification workflow involves the activities whereby a provider, as part of the care delivery process, updates a patient's medical record within a data source. The data source, based on the changes in the medical record and existing subscriptions, will notify the SDA of the changes in the medical record. The SDA will perform actions such as querying the data source for additional data, scheduling a reporting job, or creating a report for submission based on the notifications and the knowledge artifact information. This is the notification workflow. Let's move on to the next slide. Let's talk about the notification workflow steps. The step N1 is the provider, as part of the care delivery process, updates the patient record within the data source. The data source will notify the SDA about the changes in the patient record based on subscription. Upon receiving a notification, the SDA queries the patient record from the data source using FHIR APIs to evaluate if reporting needs to be performed. The SDA receives the data from data source based on the queries in the step N3. Depending on reporting parameters and data received from the data source in step N4, SDA may perform internal processing such as setting up scheduled jobs for reporting at a later time or designating that there is nothing to report. The next workflow is the report creation workflow. The report creation workflow involves the activities whereby the SDA collects the data necessary for creating the report to be submitted to the data receiver. The SDA may then perform additional activities such as using a trust service provider for pseudonymization, anonymization, hashing, or de-identification based on the specific use case need defined in the knowledge artifact. Finally, the SDA assembles the data in the required reporting format for submission. This is the reporting workflow. Let's move on to the next slide. Let's talk about the reporting workflow steps. The first step is the data collection and submission report creation workflow, which is triggered for a specific patient based on the output of the notification workflow. The SDA queries the data source to retrieve the necessary data for the patient to create the submission report. The data source returns the data for the queries from step D2. The SDA processes the data returned from the data source, applying necessary filters and the logic as appropriate. The SDA, based on the type of submission, will invoke the trust services provider to de-identify or pseudonymize, hash, or anonymize the collected data before generating the report. The trust service provider returns after de-identifying or pseudonymizing, hashing, or anonymizing the data based on the request in step D5. The SDA creates a submission report from data collected for submission. Step D5 and D6 only occur if the information in the knowledge artifact requires de-identification, pseudonymizing, hashing, or anonymizing. The next workflow is the data submission workflow. The data submission workflow involves the activities whereby the SDA packages and submits the data to the data receiver. The data submission may occur through a trusted third party, also known as TTP. This is the data submission workflow. In this particular workflow, the data submission workflow starts after the report is generated by the report creation workflow and the report is validated. The SDA uses the FHIR APIs to submit the report to the trusted third party or the data receiver directly based on the authorities and policies. When data is received by the trusted third party, it forwards the data to the data receiver based on applicable requirement, authorities, or policies. The next workflow in this process is receiving response acknowledgement workflow. The receiving response acknowledgement workflow involves the activities whereby the data receiver provides a response back to the healthcare organization. This workflow depicts the push method, for example, push from data receiver to the healthcare organization. This is the receiving response acknowledgement workflow. And talking about the detailed steps and the actors, the data receiver workflow analyzes the data received from data submission workflow and crafts a response to be sent back to the submitting healthcare organization. The data receiver then submits the response or acknowledgement to the healthcare organization directly or via trusted third party based on authorities and policies. The trusted third party routes the response or acknowledgement received from the data receiver to the healthcare organization. The SDA receives the response or acknowledgement and re-identifies the data as needed. The SDA forwards the response or acknowledgement back to the data source. Now, a couple of additional workflows that are designed are for data to be populated in a data mart. These are currently not being used for the purpose of FHIR Connectathon, but let's deep dive into it. The figure below shows the research abstract model to onboard a data partner who can contribute data from their data source system to populate a data mart. Talking about the steps, the SDA initiates a extraction process to get data from a data source for one or more patient. The SDA then uses the trust services provider to de-identify, anonymize, hash, or pseudonymize the data. Once the data is transformed in step S2, the data will then be populated into the data mart. The transformation process is not part of the MedMorph scope. The final workflow of this process is populating an externally hosted data mart from a data source. In this particular workflow, the SDA initiates an extraction process to get data from a data source for one or more patient. The SDA uses the trust service provider to de-identify, anonymize, hash, or pseudonymize the data. Once the data is transformed in step S2, the data will then be populated onto the data mart. The transformation process is also not part of the MedMorph scope. So this is all about MedMorph implementation guide in detail. CDC along with White House is committed to improve the health outcome of US population. We are part of this journey. Let's make this happen. Thank you for watching this video. Please like and subscribe to my channel for future update. I will see you guys in my next video. Have a good one.